I guess there's people that are coming on board. Okay, so this is, it's hard to do a presentation in a large group format like this. Normally I would just, if I were in a typical setting, just say raise your hand and we'll address questions as we go through things. I think for Zoom presentations it may just be a whole lot more straightforward if you can certainly enter the questions in the chat, but just I'm working off one screen, so I'll address questions at the end, and hopefully not having your answer to your question right away won't derail the line of thinking here. But I'm at the University of Southern California in Los Angeles, and I'm a sleep surgeon. I'm board certified in sleep medicine as well as in otolaryngology, head and neck surgery. And we have a fellowship here in sleep medicine, and I also have a sleep surgery fellowship for surgeons. And it's, we're very much part of this lecture series, and it's wonderful to join you again. I gave a talk a few years ago about sleep surgery in general, and this one will be more focused on a specific approach that involves a wonderful collaboration between surgeons as well as sleep medicine providers. So I have a number of disclosures. Two of them are relevant to the talk today. I received research funding, no direct compensation to me, but we're part of the Inspire Medical Systems funded post-approval study and the registry study that they have ongoing. I also am a consultant for a company that's starting some early work with hypoglossal nerve stimulation called Nyxoah. And I'll very briefly mention that. So we want to always enrich the discussion of theoreticals with actuals of having a case presentation. So this is actually a South Asian female another high-powered attorney had changed the case. She had moderate to severe obstructive sleep apnea with some desaturations and really is profoundly sleepy. And both based on her Epworth Sleepiness Scale score of 14, and she had, using the Functional Outcomes of Sleep questionnaire, a questionnaire that measures sleep-related quality of life, she had a moderate decrease in this component of quality of life, basically meaning that she limited her activities because of being sleepy or tired. And she was unable to tolerate positive airway pressure therapy. She just could not initiate or maintain sleep. And so she came to be specifically interested in hypoglossal nerve stimulation, as many patients do. So we are going to discuss this case in the context, a broader context, I should say, looking at obstructive sleep apnea's surgical evaluation. What I do as a surgeon when I see someone who's not tolerating positive airway pressure therapy, we'll obviously spend the bulk of the time looking at hypoglossal nerve stimulation for obstructive sleep apnea, and intermixed in that, we'll be discussing outcomes of this therapy and placing it in context of other therapies that we have available. So the overlying theme of this, and really all my lectures, is that not all sleep apnea patients are the same. The patient on the left, who had actually moderate to severe obstructive sleep apnea, very different from the patient in the middle, who's got a very small mandible or lower jaw, and they were treated totally differently. The patient on the left did well with traditional approaches, whereas the patient in the middle really needed to move directly to maxillomandibular advancement or jaw surgery, which we did, and she got a really nice result. But it's something where it's a totally different kind of patient. Similarly, the patient on the right, patient on top who has pretty small tonsils, what we would call 1+ tonsils, versus the patient on the lower right has these enormous tonsils. Those would be 4+ tonsils, so much bigger, filling up the entire throat. And we do see those patients, but not that often, because often they've had their tonsils taken out as children if they're that size. But those are certainly the patients that do very well with considering surgery. But you certainly would treat that patient and expect different results than you might expect with the one in the upper right. And so the best way to summarize this is this image taken from my website, and basically indicating that effective surgery must be directed at the site of obstruction. I mean, honestly, we're just dumb surgeons. They give us the sleep apnea, and it's obviously more than just an anatomical problem. But when it comes to surgery, like oral appliances, actually, they're both anatomical treatments. And you really want to get a sense of where someone's having upper airway obstruction. And so if you have this drawing here of the upper airway, you think of it as these three general areas where people can experience obstruction. one being the nose, one being the palate and tonsil region, and then one being this region down lower in the throat that I call on my website the tongue region, but really really is referred to sometimes the hypopharynx, which is somewhat of an incorrect name because it includes technically the hypopharynx and a part of the oropharynx. Anyway, it's also called the retroglossal or retrolingual region, and in the sleep surgery literature, these are all interchangeable terms. But the idea behind this is that you want to figure out where the blockage is happening, because that's where you're going to treat. Sort of like the saying from Jesse James and asking why he robs the banks, because that's where the money is. And the same kind of thing that you want to figure out where people are having blockage in breathing and treat them accordingly. And contemporary sleep surgery, there's all these options. I don't do all of these, but I mean, these are what are available for obstructive sleep apnea. It's a little bit dizzying because there's so many options that are available. And the question is, how do we choose from among those options? And I think the importance of having multiple options was underscored by the first major review of the sleep surgery literature published almost 25 years ago. At the time, UPPP, the traditional uvulopalatopharyngoplasty, was really the primary option that was available for most patients. And this review showed that UPPP was successful, and we can quibble about what that means, but the responses that we might like to see occurred in about 40% of all sleep apnea patients, which honestly, it's not great. It's better than zero, but it's not great. I think the really important thing that came from that work was that if patients were what we called Fujita type 1, having obstruction primarily at the soft palate, they did not great. They did about a 50% response rate, which was okay, but it was definitely better than the patients who were these Fujita types 2 and 3 patients who were felt to have some component of obstruction down lower in the throat, in that what we call the tongue region or hypopharynx. And so one of the major conclusions of this review was that the failure to identify sites of obstruction is a principal factor in poor results for surgery. This has been underscored by many groups, including the Cochrane collaboration and their Cochrane Collection 2005 Evidence-Based Medicine Review. One of these conclusions was that more research should also be undertaken to identify and standardize techniques to determine the site of airway obstructions. And so this came out right as I got going in my career in sleep surgery. And basically, you want to build on the work of previous individuals and previous researchers. So I think there are at least a couple of surgeons on the call, and I think many of you come from a pulmonary background. You're very familiar with these fiber optic endoscopes shown there in the lower left. In otolaryngology, this is the flexible fiber optic endoscope we use, the flexible fiber optic laryngoscope. It's not quite as long as the bronchoscopes, but the people had a long time ago the idea of saying, well, if we're looking at finding out where people are having obstruction during sleep, why don't we take these scopes that we have and look inside the airway, passing them through the nose and into the throat, and looking both up high in the throat as well as down low in the throat to get a sense of where an individual patient might be having obstruction. Because, of course, patients are different. And so there actually is one additional publication that I was involved in from the past few years. But for a long time, these are the only 2 publications that were available from the late 70s and early 80s. And the reason is, as you might imagine, it can be challenging for patients to not only fall asleep, but stay asleep with the flexible scope in their nose and throat and moving it around to look at these different areas of the body. So that natural sleep endoscopy was sort of left by the wayside. And it turns out in a couple of centers in Europe, they developed this technique of drug-induced sleep endoscopy. It was first described about 30 years ago in a center from the UK. And basically, for a long time, it was used in several centers around the world, but much less common in the United States. As you'll see, it's used much more now than it had been for a long time. The basic premise of it is this fiber optic endoscopy of patients under sedation. So that's the drug-induced part of it. But you do sedation in a specific way to try to reproduce those patterns of sleep disordered breathing that are seen on a sleep study. So you don't diagnose sleep apnea. Patients will already have a sleep study, but you want to produce those same kinds of obstruction of events, these disordered breathing events that are seen on a sleep study. And actually, when we do it, we looked at the patient's sleep study. They had a lot of apneas. We want to be seeing apneas and vice versa for hypopneas. And so again, it's not for a diagnosis of sleep apnea, but it's a surgical evaluation test to identify where obstruction might be occurring. And so with a couple of European colleagues about 10 years ago, we developed the VOTE classification. And the idea behind it is that people were doing work for years, in some cases decades, and really everybody had their own way of looking at describing what they saw under sedation. And the idea behind developing what is now pretty much the standard classification system in adults, at least, is to basically speak a common language, to compare findings and outcomes across various centers. And it's been used in a couple of big studies that I'll reference later in the talk. Everybody okay? Okay. So in the upper airway, there are various structures that contribute to upper airway obstruction. I've listed the main things that we think about here. Obviously, some people may be having nose or nasopharynx obstructions. Nasopharynx obstruction very important in children with adenoid hypertrophy or hyperplasia. But the nose by itself in adults is not the most common source of significant obstructive sleep apnea. It's pretty uncommon. Shown in red, or at least for first letters in red, are the structures that contribute to the acronym of VOTE, being the velum or palate, including not just the soft palate, but also the uvula and the sides of the throat at that level of the palate, what is sometimes called the lateral velopharyngeal walls. Down lower in the throat, the sides of the throat, which include the tonsils, but sometimes the tonsils can contribute to the soft palate obstruction as well. But the side of the throat is a little bit of different issue, as you'll see, and that's where the O of VOTE comes from, the oropharyngeal lateral walls. T is for tongue or tongue base. I mean, we're just seeing the tongue base when we look with the fibroscope, but it can relate to the entire tongue. E is for the epiglottis, and L, which is not such a common source of airway obstruction, but can occur and can play a role, but that's for larynx. So with those four structures, that's what contributes to and what you evaluate with the VOTE classification. And what you do is you look at what is called the configuration of the obstruction. Basically, there could be collapse in a front to back pattern, which is the anterior-posterior, side-to-side pattern, lateral collapse, and then a combination of the two, what is we call the concentric collapse. Not all structures can obstruct in all configurations, but these are the very basic front to back, side to side, and a combination, the different kinds of things that theoretically can occur with obstructing the airway. And of course, you can sometimes look at the degree of narrowing, and it's still a qualitative assessment, so you have to make some judgments. But 0 would be no obstruction, typically associated with no vibration. 1 being partial obstruction, typically with some vibration, at least for structures that can vibrate. And 2 are complete obstruction. It doesn't have to be 100%, but it can be, if you think about it, at least 75% compromise of the airway, but a pretty substantial compromise of the airway. And typically that may not actually be associated with any vibration because the airway may be completely obstructed. You combine these into a table, which is from our paper back about 10 years ago. You have the structures listed in the first column, the degree of obstruction, and then these configurations that can occur. For example, the soft palate, you can get anterior-posterior obstruction, lateral sort of side-to-side obstruction, which isn't that common for the palate, and then a combination of the two, what is called concentric collapse. We'll come back to that later. If you see a couple of the boxes are blacked out because you don't really have anterior-posterior collapse of the sides of the throat, it's really going to occur in a side-to-side pattern. And the same is true for the tongue or tongue base, that it really just falls backwards. And so that's the anterior-posterior configuration is the only one that you really see with the tongue obstruction. So because this is usually the most enjoyable part of my talks is showing some videos. So V is for velum or palate, and we're going to look at some examples. I will orient you. The posterior pharyngeal wall, so the back of the throat is on top of the screen in all the videos. Here is a soft palate at the bottom of the screen, and you can see the uvula hanging down. And this is someone that has fluttering of the soft palate and uvula. Their airway actually isn't that obstructed compared to most people, but it's something that they're certainly making snoring sound there. Contrast, again, the posterior pharyngeal wall. What you see here is the airway, the space for breathing is collapsing in all directions. This is an example of what we think of as complete concentric collapse. And here's someone that really never gets the airway opening at all. It turns out that this patient has markedly enlarged tonsils. And the idea is that you don't look at drug-induced sleep endoscopy on its own, but you look at basic physical exam, the tonsil you can see in the mouth. Here's the uvula saying hello. Turns out I don't have many videos like this because we don't actually often do drug-induced sleep endoscopy when people have tonsils that are this big, because really the airway is so obstructed physically just by those tonsils. But that's pretty common. The idea that velum or palate-related obstruction occurs, that's been felt to occur for a long time. But what I hope to show here with moving through these structures is that there are other things that can play a role. So O is the oropharyngeal lateral walls. What you see in the distance towards the bottom of the screen is sort of the bumpy surface, is the back of the tongue. The middle of the screen, and if you look at the epiglottis, is this curved the tongue and the larynx. And if you look carefully, the and everything else are not falling backwards. It's really just the sides of the throat that are caving in. Another example, the tongue may be sitting back a little bit. These, by the way, so these structures can occur in combination as far as playing a role in airway obstruction. The tongue is maybe sitting a little bit farther posteriorly, but it's really the sides of the throat that are impressively collapsing. These are both examples of complete collapse related to the oropharyngeal lateral walls. So T is for tongue or tongue base. Tongue, you see in the distance, it's that bumpy surface there, and the view is blocked a little bit by the soft palate right here. So I advance the fibroscope. And what you see is the tongue is blocking the airway. And it might not be a big surprise, these kinds of patients, if this is what's happening during sleep, then isolated soft palate surgery is not going to address the obstruction. I mentioned the structures can collapse in combination. So here the tongue is falling back and pushing this epiglottis against the posterior pharyngeal wall and giving a very funny snoring sound. I love watching the videos with couples and basically asking the bed partner whether these snoring sounds are familiar, and usually they'll start already be pointing at the screen, indicating that this is what I have to listen to every night. But E is for epiglottis. So sometimes the epiglottis by itself will fall back and obstruct the airway. You actually see the tongue at the way bottom of the screen, but here the epiglottis is just falling back on its own. Not the most common finding, but about in 5% of all sleep apnea patients. So here the tongue is maybe sitting a little farther back, but really the epiglottis is moving on its own. And there are various reasons why this might occur. There may be some looseness of tissues that allow the epiglottis to fall backwards. Okay. So, drug-induced sleep endoscopy, the idea behind it is that it is a dynamic assessment of patients during and quote-unquote sleep, because you can directly visualize location of obstruction, albeit under sedation. I won't bore you with all the details, but a few studies have looked at what we call validity, showing greater collapsibility in sleep apneics against snorers, and then if you lump sleep apnea and snorers together as sleep disordered breathing patients, comparing them to controls, basically at increasing doses of various sedatives, primarily propofol has been studied, but you basically mirror reality, showing that there's greater airway collapsibility in those that have it during natural sleep. With low doses of propofol, the apnea-hypopnea index does not seem to be changed. A study out of Brazil shown there, Fabio Rebelo. And there were some, for a long time, pretty limited studies showing a correlation between sleep endoscopy findings after soft palate surgery, as well as multi-level surgery, and even some, I guess, fairly qualitative studies looking at association between sleep endoscopy findings and mandibular advancement device or oral appliance outcomes. But the last point is, I think, what's felt to be the most important aspect of why we do drug-induced sleep endoscopy is that this region down lower in the throat, the hypopharynx, the retrolingual region, the tongue region, whatever you want to call it, it really has these different structures. And the idea or the belief was that their patients respond differently whether the obstruction is related to the oropharyngeal lateral walls, the tongue base, or the epiglottis. And there are some disadvantages, of course, to drug-induced sleep endoscopy. It's not easy. It requires requires sedation. So in the United States, primarily it's going to the operating room, sometimes an endoscopy suite. Of course, it's time consuming. You have to be a little careful with sedatives because they do decrease muscle tone and decrease respiratory drive. And so you don't want to artificially worsen sleep apnea and alter the pattern of collapse. I think David Hillman, a team in Australia, they've done some really important work showing that propofol, if you studying with propofol, but if you look at patients as they lose consciousness, basically not responding to their name being called, you actually get something that has some real similarities in terms of muscle tone, in terms of other measures of physiology. It's in the range of REM and non-REM sleep. So it's something that's not reproducing sleep, but it is somewhat in the neighborhood. And that's what a lot of high-profile upper airway physiology researchers have confirmed and reassured me as we've done research related to this. And we use propofol because it's been studied the most, and it seems to have less decrease in respiratory drive than something like midazolam, a benzodiazepine. So really, the study that got me interested in looking at sleep endoscopy, the question listed here at the top was whether sleep endoscopy findings are associated with surgical outcomes. I mean, it took me about 15 years before we had this multi-center study that Catherine Green, one of our former fellows, who's now at the University of Colorado, she led the work, but we got people together for this multi-center study of 14 centers from around the world, and a sample size that in the surgery world, that's a pretty decent sample size, and in CPAP study world, it's not the largest study, but anyway, we took a fairly good group of patients and we did a blinded review of pre-recorded sleep endoscopy videos. So these are patients that had surgery. They had preoperative drug-induced sleep endoscopy with the video recorded. And what we did was we had 4 otolaryngologists reviewing the videos without knowing what surgery was done, without knowing what the results were, and looked at whether the findings from before surgery were associated with outcomes. And we had this way of combining our ratings across 4 surgeons to get a consensus assessment. And so the conclusions are just summarized here, that first of all, if patients had any component of significant oropharyngeal lateral wall related obstruction, basically the sides of the throat were collapsing, whether it was partial or complete, that was associated with the decreased odds of getting this kind of result we'd want to see, called a response to surgery. But that was bad. Complete tongue-related obstruction, so not so much partial, that was associated with a similar kind of decreased odds of responding, and especially if they didn't have tongue surgery performed at the same time. And if they did have tongue surgery, we didn't quite have enough study participants that had some of these tongue resection procedures that we'll allude to later. But you basically need to have the slightly more involved procedures. We think the p-values weren't quite perfect, but that was the suggestion from the data. If you had complete tongue-related obstruction, you need to have somewhat of a more involved approach to treating that tongue-related obstruction. And this is, by the way, for surgeries that do not include hypoglossal nerve stimulation. We didn't have a clear association between results and findings related to the soft palate, including this complete concentric collapse, which actually, people thought that was going to be something bad for all kinds of procedures, but we didn't see that specifically in our study. And then we didn't have that many or enough study participants with epiglottis-related obstruction, and so we couldn't make some firm conclusions about that. So now we're finally getting to hypoglossal nerve stimulation. It'll all come together, not to worry. But hypoglossal nerve stimulation is not a new idea. There's been a lot of research going back to the 80s and 90s on stimulation of both the tongue muscle directly and the hypoglossal nerve itself in sleep apnea patients as well as in animal studies. And so Medtronic made what was the Inspire One device. Again, we're talking about the 1990s. And it basically functions somewhat similar to what we're doing now. They basically used, Medtronic, obviously a big cardiovascular device company, and so they felt that if we could get an implantable pulse generator, shown here on the diagram as the IPG, and connected to a sensor lead, which was at that time a transsternal sensor, basically putting a little hole there in the sternum to really secure that lead, and looking at respiratory effort, respiratory patterns, and based on timing that, stimulating through this red lead, the stimulation lead, to a cuff placed on the hypoglossal nerve, or more specifically a half cuff, meaning it only was like a semicircular covering the hypoglossal nerve. And so, again, this is a study from a long time ago, and this is the kind of results we saw. So obviously a very condensed portion of what we see during polysomnogram, but basically with stimulation off on the left side, The best way to look at it is the airflow tracing, just for simplicity purposes. But basically, you have airflow that, pretty significant obstructive sleep apnea with periodic decreases in airflow, and then with stimulation on a much more stable, normal respiratory patterns of airflow, at least. And what you saw with other measures captured during PSG, substantial improvement, including oxygen saturations there at the bottom. So it could work well. And it turns out they only implanted 8 patients at 4 centers, US and Europe. And what you see here is baseline. The white bars are for non-REM sleep. The striped bars are for REM sleep. There was a notable improvement, not perfect by any means, but a notable improvement in the apnea-hypopnea index, from a mean of 52 down to about 22. And improvement in airflow, the Vmax. The problem was the devices broke down. 6 months or more after implantation, 5 of the 8 devices broke, and actually one of the pitfalls was related to the leads, not so much the device. But I think in more learning, we found that the electrode design, putting almost like a semicircle coverage, the half cuff electrode, was probably not the way to go. But basically, Medtronic was like, yeah, it's interesting, but they basically withdrew support for the program and replacement parts. And so treatment was suspended in cases where the devices broke, and then abandoned after the remaining patients had the battery, the power supply ran out. So it was largely abandoned. That was the bad news. But basically, as the patents ran out, 3 companies picked this idea up. And this was, again, about 10 years ago. They picked this up, or maybe a little bit more, but Apnex Medical, Inspire Medical, and at that time, Imthera picked up this work. And I worked for a long time with Apnex Medical, a company that does not exist anymore. But basically, I'm going to show you some work related to them, and then, of course, focus on the Inspire Medical Systems device. And we'll come back to the Imthera device a little bit later. So obviously, we want to treat sleep apnea. And so you have this system that delivers hypoglossal nerve stimulation. I'll talk more about it. But the big question that comes up is, do we improve airflow? And then does it wake patients up? So again, many things here from data that are collected on a PSG, but we'll focus on airflow here towards the bottom. And what you see is I, or inspiratory airflow, is a downward signal, and expiratory airflow is upwards. And what you see here is the inspiratory is pretty flattened, associated with airway obstruction. And so this is, at the bottom, a certain level of stimulation, 1.7 milliamps, which is the way that this system was set based on the intensity of the stimulation. And so if you're not getting the airway open and good inspiratory airflow, you turn it up. And the middle, component here is at a 2.0 milliamp setting. And what you're getting is that when you have stimulation, which was delivered on every other breath, and what you see, I don't know if you can see my pointer, but you see there's a stimulation, a higher tracing, sort of this box pattern, you start getting some inspiratory airflow. But it's not really a normal inspiration, because there's a spike of airflow, but then there's this flat component right afterwards. And as we know from looking at PSGs, that's airway obstruction. And so what you do is then turn it up. And what you see here is a higher intensity of stimulation, and you're getting a normal airflow pattern of inspiration and expiration. And the important thing is you can't quite see it from the limited EEG signals that we have here, but actually the important thing is you're not waking people up. And how do I know that? Well, when you don't stimulate, the breaths that are unstimulated, you're not getting any airflow. And if you're waking someone up, just like we see with arousals from disordered breathing events, that's when you get normal airflow. And so that was a very important finding acutely, that you weren't waking people up. And that's shown here in that you have stimulated breaths in blue, unstimulated breaths in red. And as you increase the amplitude of stimulation on the x-axis, you get an increased airflow until you get to a certain level where you get this peak flow threshold, and where turning it up doesn't really seem to offer much benefit. These are studies of Apnex. It very much mirrors what we know and how Inspire Medical Systems device works. And now we'll go directly into that therapy. So Inspire Medical Systems makes the only FDA-approved technology available in the United States. It is a fully implantable system that involves basically this implantable pulse generator, effectively a pacemaker, a sensing lead curled up here, but a sensing lead that's placed, you can see in the diagram here, placed between intercostal muscles, and it senses respiratory patterns so that you know when people are breathing in or attempting to breathe in, and the same is true for expiration. And gets that pattern of the respiratory cycle and takes that information and through the stimulation lead delivers it up here in the neck to the hypoglossal nerve, a certain portion of the hypoglossal nerve where branches go to muscles that move the tongue forward. And so these three components are placed inside the body during a surgical procedure. Many of you may have already seen this during your fellowship year or beforehand. And patients get a remote control to turn it on. And there's nothing that sticks out of the body. These remotes, like many implantable devices, communicate through radio frequency. And patients get a start button. They can turn the intensity of stimulation up or down within a range. And they get a pause button. For example, if they're sleeping with it on and they need to go to the restroom in the middle of the night, they can press pause so they can go to the restroom, come back, fall asleep, and have the device come back on automatically. So that's the way the system works. It involves this collaboration because it's placed by a surgeon, but then generally it's the sleep medicine team that will make various adjustments and figure out what the right settings might be. And this is what is seen during some of those evaluations, similar to what was present with the Inspire One device from Medtronic. Basically, you have, with no stimulation here on the left, if you just look at the airflow signals, both of them show these periods of apneas. And on the bottom associated with oxygen saturation. And, obviously it's a nice example is picked, but you see the airflow is normalized and stabilized, and the same is true for oxygen saturation when you have stimulation. So why is this available? Well, the major study of Inspire, what they're called pivotal trials, it was published in the New England Journal of Medicine. And there are definitely a number of studies from the positive airway pressure therapy world, but there are not many from the sleep surgery world that are published in the Journal of Medicine. The reason why it's published is because the results were fairly impressive. And so this study was a single-arm trial, meaning everybody had the device placed and had it turned on. 12 centers in the US and Europe. The primary outcomes were related to safety, of course, but also to efficacy. And there were different measures of efficacy: the apnea-hypopnea index, the oxygen desaturation index, the quality of life measure that I mentioned before, the functional outcomes of sleep questionnaire, daytime sleepiness measured by the Epworth Sleepiness Scale score, and oxygen saturation. And of course, the key entry criteria were things that you might expect: failed positive airway pressure therapy. There was a range of apnea-hypopnea index severity that was allowed for entry into the study. An important aspect of the study was that it was limited to body mass index below 32. There was a pretty wide age range. Importantly, study participants were only allowed to have minimal central or mixed events. So less than 25% central and mixed events for entry in the study. The idea being that you want this sensing lead to sense a pattern of respiratory effort in order to alleviate obstruction, whereas it wasn't something like the Remedy device that can treat central sleep apnea. And importantly, and the reason why we talked about drug-induced sleep endoscopy, is that a requirement for entry into the study, which is still a requirement for anyone who would get implanted with this device, this system, is performing drug-induced sleep endoscopy prior to implantation. And the study excluded patients with that complete concentric collapse related to the palate that we discussed earlier and that I showed you. They were excluded from implantation. The idea being there was some limited evidence, and I want to emphasize limited evidence, that those patients did not do as well. Turns out that probably was a pretty fortuitous decision, but it's not totally clear that they don't do well specifically. But that is the specific finding on drug-induced sleep endoscopy, which would not allow you to proceed with the implantation of the system in this study, and which also holds up to be the case now. So here's a schematic view of the timeline for the study. There was a screening polysomnogram. Patients got implanted with the device left off for a month. They had it turned on a month after implantation, then had a titration PSG, somewhat similar to the positive airway pressure therapy titrations that we do, obviously, for other therapies. But the idea is you figure out the right settings and let someone build up to that settings with therapy on, and they had a repeat sleep study at 1 year. I'll show you those results, but I'll also show you results for what was called a randomized withdrawal study. So they took the first 46 participants that responded well, so not all comers, but the folks who responded well, and for a week they turned it off in half of them and did a repeat sleep study in those patients or participants, and then they turned it back on, and then they've done long-term follow-up up to 5 years. So what were the results? Well, it's a busy slide from the New England Journal of Medicine article. I want to just focus here on the top. The apnea-hypopnea index score that at baseline went from a mean of 32 down to 15. and median apnea-hypopnea index went from 29 down to 9. So you can argue about which one is more appropriate for thinking about results, but both of them were, statistically significant and pretty meaningful results. Maybe not perfect, of course, but these are the kind of results you'd want to see to really say that you had a notable improvement in sleep apnea, certainly with the median scores of 29 down to 9. I think what's important is that it was mirrored in the other measures of outcomes, I guess, the oxygen saturation index, as well as quality of life, sleepiness, and oxygen saturation metrics. And so this is why the results were fairly compelling and why this is a real important option for patients with obstructive sleep apnea who do not tolerate positive airway pressure therapy. So this was the withdrawal study. And to me, honestly, this is more important than that first study because you really want to make sure that the effects and the benefits you see are not related to some other factors. And so the way you do that is just by taking it away for a short period of time. And so again, these were 46 people who responded well. You can see on the top for apnea-hypopnea index, but the results are similar on the bottom. But they took everybody in both the dark bar and lighter bar, and again, they were responders. So the AHI was about 30, dropped down to between 5 and 10. And again, these were the 46 responders. People responded well, and half of them, the light bar, had it turned off for a week in a repeat sleep study, showed that they had their sleep apnea pretty much coming back to where it was. And then they turned it off, and the sleep apnea went away. Whereas the patients that had their device left on the whole time, their sleep apnea remained well controlled. And so to me, that's the most compelling thing. And we generally don't have that kind of evidence for anything in medicine, but certainly for surgical interventions, because you could turn the device off and then turn it back on, you weren't getting some random thing like weight loss happening dramatically in that short period of time. But it's also important that their long-term results are pretty good. So here are 5-year results, again, off these different outcome measures: apnea-hypopnea index, upper left; sleepiness, upper right; quality of life, lower left; and response rates. And all of them show that these benefits you see at 12 months really do hold up over 60 months. Some patients come a little bit in and out of the responder group, and there's some variation over time, not tremendous, but overall the results hold up pretty well, which is, again, important in looking at 5-year results. It wasn't for everyone that was included in the original study, the 126, but it was for most patients, and the results have held up pretty well. And the reason why goes back to drug-induced sleep endoscopy. So at the bottom, the tongue-based airway, you basically, as you go across the pattern of, from one image to the next, you increase the intensity of stimulation. So what you see is the airway at no stimulation, the first image at the bottom, is pretty narrowed, basically not much change at first sensation. Once you start seeing some bulk movement, the tongue actually moving forward, the airway is opening up. It gets a little bit bigger as you go to what would be the therapeutic setting, not tremendously bigger as far as the picture on the bottom, but then at sub-discomfort, which is even a higher intensity, there's a little bit more airway opening. So that's fine, you open the airway at the level of the tongue, but it turns out you actually get some benefits at the level of the palate. And what you see in the top row of images at no stimulation, the airway is pretty obstructed. Pretty similar at first sensation, but as you go to greater intensities, you're starting getting the airway being pulled forward. And it's not as clear in this set of images, but it turns out that in a group of patients that were studied in this study, you get it at the palate is primarily occurring in an anterior-posterior direction as far as the palate, whereas in the tongue base, it's occurring sort of in both directions. It turns out that this German group did a nice study looking at 20 study participants, so a relatively small study, but they did awake endoscopy as well as drug-induced sleep endoscopy, and basically that similar patterns. They selected patients that had similar patterns, and some did well, some didn't do well. And what they did was drug-induced sleep endoscopy also with stimulation on. And they saw that some people had, because you're stimulating the right hypoglossal nerve, the textbooks our Netter textbooks from medical school would suggest that if you stimulate the right hypoglossal nerve, the right side of the tongue should move forward. And so you would see a right tongue base, ipsilateral advancement. It turns out that for some reason we don't really understand, certainly it's not stimulation of both hypoglossal nerves, but some patients have both sides of their tongue move forward. And so their tongue actually doesn't move to one side when it's stimulated. It actually moves forward directly out of the mouth. We think of that as bilateral tongue-based protrusion. And it turns out those people did a lot better. And if you take the people that had opening at the level of the palate, what we call coupling, that if they had bilateral protrusion of the tongue base, they had a pretty high chance, this is sort of a confusing graph, but an 80% chance of having opening at the level of the palate, which was greater than people that just had the right side of the tongue moving forward. Problem is, this was only going to find this out after someone was implanted. But the idea is that if you can figure this out beforehand, you might be able to identify patients who are going to respond really well. Before I get to some research we've done, important thing to note is that a lot of times patients with positive area pressure therapy who don't respond well, who don't tolerate it, are considered almost lost causes. And I know that's not how you treat your patients, but I think that the feeling in some studies of medication adherence would suggest that they don't wear CPAP, they don't really take their medications, that they may not be all that salvageable. But it turns out that these people who do not tolerate positive area pressure therapy, they have self-reported, turns out objective evidence that they are really using their device. And it's something that they're not lost causes. They actually can do well if we get something that is comfortable for them. And Inspire often is pretty comfortable for them. So this is self-report. There are some studies looking in sort of a complex way. I didn't want to dive into all the details, but showing that they are actually using their therapy. Not everyone does, but they are actually using their therapy in many of these patients. So I told you before these results that Catherine Green published, our multi-center study looking at surgeries other than hypoglossal nerve stimulation. We did a similar study that Phil Hewitt, one of our former fellows who's now at Mass Eye and Ear in Boston, led, looking at upper airway stimulation, the Inspire medical systems technology for hypoglossal nerve stimulation. And the idea is that we have sleep endoscopy that is required before implantation, but our only use of it is to screen out those with this complete concentric collapse related to the soft palate, which is about 30% of all patients. And then we just tell people that about a 70% chance of getting the results we're looking for. And that's okay, but what if we could identify those who had maybe an 80 or 90% response rate and those who had only a 50% response rate? That would probably be helpful information. And then there are some people who aren't comfortable with stimulation. And the idea is what we're going to be doing is looking at whether we could identify those people who'd never be comfortable with stimulation, see whether we could predict that based on polysomnogram or other measures. So to look at sleep endoscopy findings, we presented here about a year ago with studies from about 240 study participants. We've actually expanded to 375 study participants that I can't share with you because it's not published yet, but the results are pretty similar. And so overall, we had, based on the titration study, which is not as good as the efficacy studies that are sometimes done, basically studies that are done with patients having the device on all night at their ideal settings. But if you look at the titration sleep study, somewhat of an idealized situation, our response rate overall was about 75%. And so here's some of the findings grouped according to structures. And I won't bore you all the details, but I want to focus you on the items in red. So it turns out that if you have complete oropharyngeal lateral wall-related obstruction, this O2 pattern, your relative risk of response are lower. And those findings were not as statistically significant. The confidence interval almost included 1, but basically it was confirmed with this larger sample size. And that basically it's something that probably, it seems like patients don't respond as well to upper airway stimulation if they have complete lateral wall related obstruction. But they do respond really well if they have complete tongue related obstruction. So with other surgeries, I told you that complete tongue related obstruction was bad. Here it's actually really good, because if they have complete obstruction, it's actually probably the tongue is a big part of their sleep apnea. And so we had a little over 80% response rates in those who had complete tongue-related obstruction, because you move the tongue forward. It's not that complicated. We're just dumb surgeons, but the tongue's the problem. We treat the tongue pretty well with Inspire therapy. And basically, those patients responded pretty well. Those numbers became statistically significant with our larger sample size. So the ideal candidates for upper airway stimulation, which is, again, the one that's available here in the United States, is those who are not adherent or benefiting from positive airway pressure therapy. The FDA criteria include a slightly wider range of apnea-hypopnea index, and the FDA indications are below 25% central or mixed events, but in reality, it's probably you want less than 10%. And that comes from recommendations of the company, what they've seen in larger numbers of patients that have been implanted over time. So you really want to have pretty much almost exclusively obstructive sleep apnea. Medicare actually allows implantation up to 35 body mass index, and some payers will consider patients like that, but in general, it's felt to be below 32, but it does vary by payer and certainly can be very important. I think we all know that body mass index is a very crude measure of obesity, and we know also the importance of obesity in terms of tongue fat. But the idea is that some people with BMIs even above 35 are very thin in the head and neck area, and they probably respond very well, and they have responded very well to upper airway stimulation or hypoglossal nerve stimulation. Where some patients who have lower body mass index, there's just too much stuff there, whether it's because of muscle mass or fat deposition, but they're not going to have alleviation of their sleep apnea with it. But those are the numbers that are sort of considered for insurance approval. There actually seems to be greater efficacy in those adults who are age 65 years and above, probably because low tissue tone is a bigger part of their sleep apnea. So if they have primarily obstructive sleep apnea, they actually respond really well. My experience, and I think from those of us who do a lot of this, is that if you have pretty significant, especially unstable insomnia, whether it's initiating or maintaining sleep, you do not do well with upper airway stimulation because often you can't get fully comfortable with it. You're waking up a lot during the night anyway, so you're having to hit the pause so often that you're losing time where you might be stimulated and getting the benefit of therapy. And so it's probably not a great idea. I've had to explant some of our own implants as well as a couple from a few other centers. So it's not a common thing to have to explant, but because really bad and difficulty initiating or maintaining sleep is not super common with sleep apnea, but it certainly can occur and something to be aware of. I mentioned that sleep endoscopy is required, and really if you have this complete concentric collapse related to the palate, you're not considered eligible for hypoglossal nerve stimulation. I would propose there may be an additional role for drug-induced sleep endoscopy, certainly in counseling, based on this work that we did, which was pretty rigorous scientifically, but that's not part of the actual indications that are used by payers. And then this idea of bilateral protrusion, if we could figure that out in advance, that would be nice because those patients seem to do a little bit better. They get more multi-level airway opening because the palate can also open up when the tongue is advanced, especially if it's bilateral. So the future is that, again, right now the device on the left, the system on the left is what we have available, but Inthera, now the technology owned by a company called LivaNova is shown on the upper right. They did a large study that they did not release the results, which sometimes leads you to think the results were not that great. I believe they're gearing up for another study at some point in time. Nyxoah, which is a company with which I'm involved, they have a bilateral hypoglossal nerve stimulation technology. This is an image from their website, so I'm not sharing any proprietary information. There are other companies that are out there that are looking at various approaches to hypoglossal nerve stimulation. So I don't think that we're at the end, but certainly we have a technology that's got over 100 publications now, really showing that this is a very important option for patients who are not doing well with positive airway pressure therapy. So going back to our case, here she is, the 58-year-old female attorney. She very importantly points out, when the first time I saw her, that she does malpractice defense. Not that it would make that much of a difference, but actually here's her numbers. I'm sorry if I didn't change the other slide, but moderate severe sleep apnea, desaturation, tired, unable to tolerate a positive airway pressure therapy. She was interested in this hypoglossal nerve stimulation. Her tonsils had been removed as a child. She had what's called modified Mallampati position 3, meaning her tongue was relatively big. Part of that was related to the fact that she had a slightly small mandible, and so there wasn't as much room for the tongue. But the tongue itself was a little bit big, just the way she was built. I mean, it has a little bit muscle tissue, but a little bit of fat deposition in this area of the body. So the awake fiber optic examination in the office showed she was, sort of borderline narrow to the palate and behind the tongue, but that's people being awake in the office. Here was her drug-induced sleep endoscopy. Imagine we implanted her and activated her 3 or 4 weeks after surgery. It's important to know that actually, even though you turn it on when you activate the system at a very low setting, you often, even though it's not fully therapeutic, people will notice some difference within those first couple of weeks. So what you do when you activate the system, you turn it on at a low intensity, and you gradually build up to what might be the final intensity, determined based on the sleep study, the titration PSG, usually at 2 to 3 months following implant. The patients are usually really excited. They have to go slow, and you have to remind them to go slowly with turning it up, but they get a little range and they can gradually build up and will often notice some benefit pretty early on. And she's done great, it turns out. She's had full resolution. Her apnea-hypopnea was 7 on her titration sleep study, and she's just feeling so much better. But it's important to know that some patients don't do as well. And so what we do for that, just briefly, is you have people come into the office and you can change the electrical settings while they're awake, just in the office, do what's called an awake titration, see if there's some way to get the airway opening up better. Often one of the areas that the airway does not open is behind the soft palate, and some of the different changes in the electrical settings can improve that. You don't just crank up the intensity, but you can change how the electricity is delivered. You can do it in the operating room under sedation with drug-induced sleep endoscopy to see, again, somewhat mirroring sleep to see if that is going to get you that more airway opening. You can repeat the in-laboratory titration. It might be the timing of their stimulation. Again, there are all these different settings that are important in getting the airway opening at the right time. So there are a lot of things that we can do. And then sometimes people get palate surgery, and I've done that in a couple of patients, and really allowed them to get that combination of opening the palate with surgery, but getting the tongue moving forward with hypoglossal nerve stimulation. So I think that, we have moved to this structure-based approach a lot more in the world of sleep surgery, because we have all these different treatment options that can be matched a little bit better to a structure-based approach. And it's important to remember, though, that upper airway stimulation, there are some limitations with body mass index in terms of getting insurance approval, but it's not just a tongue-related device, but it really works well if the tongue is the key issue. And so it goes into the armamentarium of things. I use it. I don't use it for everyone with, considering surgery. I certainly perform a wide range of other procedures, and I know colleagues do as well. But I think that it's something that really is a nice option for many patients who aren't doing well. And so we know sleep apnea is common with important health-related behavioral impacts. Patients with poor PAP compliance, adherence, whatever word you'd like to use, should consider adjunctive or alternative treatment options. And airway narrowing occurs at these 3 levels: the nose, the palate, and this hypopharynx, where there's multiple structures that can play a role. And we know that sleep surgery outcomes are improved with addressing obstruction at the relevant levels. And hypoglossal nerve stimulation is an important tool in our armamentarium, treating sleep apnea in patients who are unable to tolerate or benefit sufficiently from positive airway pressure therapy. So I will open it up to questions. We've got some in the chat that I can approach. Sorry, my voice quality was not good. We did test it beforehand. I do apologize for that. We're setting up the slides as well, and I think this has been recorded. I don't know if the recording would have it be a little bit better. Does anybody have any questions about things? Right, so next, great question. So there is a battery within the Inspire Medical Systems technology, somewhat similar to a cardiac pacemaker. The device that's currently available has approximately 11-year battery life, and that's it's proven to be the case because people have not needed replaced earlier on. So 11 years is what we tell patients is battery life. Replacement similar to cardiac pacemakers, an outpatient procedure where they would open up one incision over the upper chest, take out the unit, disconnect the leads, reconnect it to a new device, put it back in, sew it up. A fairly straightforward approach to get a new device with a new battery inside there. So next question is, what is the body mass index cutoff for hypoglossal nerve stimulation? For Medicare, it is generally 35, and for most payers, it's 32. Again, it's not always something that is actual a determinant of efficacy, and there often will be some, submissions for authorization and appeals and all that for someone who might be a good candidate that doesn't fall within that body mass index range, but that's generally the threshold values for most patients from a body mass index standpoint. Next question is, hypoglossal nerve stimulation work in concentric pharyngeal collapse? So concentric pharyngeal collapse, pharyngeal, the pharynx is a big structure, so there are these different structures that play a role. So what we show with our study was that if you had complete obstruction related to the oropharyngeal lateral walls, which is a lateral collapse, not necessarily concentric, that people, the relative risk of responding, so getting a good result, was about cut in half. So it's just that they can still respond, but it's just a lower likelihood of responding. So that's something that, I talk with patients about this because I believe the results of our study. Now, when people talk about concentric pharyngeal collapse, it may be that they're saying lateral walls plus the tongue. And so I sort of separate those out. So I don't really use that term of concentric pharyngeal collapse, but hopefully that answers your question somewhat at least. So next question, contraindications, patients with other implantable devices like vagus nerve stimulator, deep brain stimulator, cardiac pacemaker. So the short answer is those devices should always be, there should be some testing involved, but it has not, knock on wood, been a problem with patients with cardiac devices. I don't know how many patients have DBS as well as, or vagus nerve stimulators, but I know that people, I don't have a lot of experience with other implantable devices, but for cardiac devices, it has not demonstrated interference, but it does need to be tested, of course, because these are life-sustaining devices. So basically, next question is someone asked if I'd ever had to remove a device, and I have. I've removed a couple of my own implants for people that had significant uncontrolled insomnia, difficulty both initiating and maintaining sleep. I've removed a couple of other devices for the same reason, and 2 patients because of low efficacy. They just thought it wasn't working, just take it out. People are asking about removing the electrodes or just the pulse generator for fear of damaging the nerve. All those things are considerations, but usually you would want to take out the entire system, obviously doing it carefully so that you don't damage any structures, including the hypoglossal nerve. Next question, as far as use with MRI. So the current device, and another question about MRI, the current device that is called the 3028 implantable stimulator has some limitations in MRI, but it is MRI compatible for many MRIs. So it allows 1.5 Tesla MRI, so not stronger magnets like 3 Tesla or some other stronger magnets that are used for research purposes, but it allows 1.5 Tesla for MRI of the head, neck, and extremities. So not the chest, abdomen, or pelvis. Similar to many other active implantable devices, it has some limitations on MRI. Also asking about residual sleepiness or AHI trying combination treatment with positive rate therapy. Well, 2 things. First is the whole reason they were getting hypoglossal nerve stimulation was because they couldn't tolerate or benefit from positive retrotherapy. So I've never done that, and it sort of it doesn't really make sense. And the same is true for thinking like an oral appliance. It's possible. I know people combine oral appliances with polyurethane therapy, which I still don't totally understand, to be honest. But the point is that you certainly would want to make sure that they're being optimized from the standpoint of hypoglossal nerve stimulation and figure out why they're not being optimized. There are absolutely patients out there that have full control of their sleep apnea but still have residual sleepiness. So those stimulants, or not actually stimulants, but wake promoting or literacy promoting agents like modafinil or armodafinil, things like that can be helpful in those study participants. But usually you want to figure out what's going on, why they're not alleviating their sleep apnea, and go from there. And it's just restarting positive rate therapy is just not really a great option because they didn't tolerate that to begin with. So practically speaking, every Inspire Center has a team of providers as well as an Inspire representative. And so it's something where you can get those checked out. Sometimes the checking is really only done after implantation, but they would have more information with things like the DBS or vagus nerve stimulation in terms of what the experience has been more broadly. The height of the patient, length of the pharynx, and whether this influences treatment. So there has not been any studies about that. I think that what you're alluding to is that there have been some work looking at length of the pharynx and risk for obstructive sleep apnea. It's not felt that would be an obvious, huge part of response to hypoglossal nerve stimulation, but who knows? I think it's certainly ample opportunities for research, and certainly I would encourage you to investigate a very interesting question. So the last question that we have as of now, which might be our last question period, is any research on patients older, younger, or outside the BMI cutoff in order to better choose patients. So there are a couple papers looking at patients with higher body mass index showing they do respond, not quite as well maybe, but they do respond well. I alluded to one study where I was a co-author showing actually at least as good, probably better response rates in those 65 years and above. And so basically, these are all, all research, it's looking at risks and statistical, probabilities, I guess. But it always boils down to the specifics of an individual patient. But certainly, Medicare initially was very difficult to get coverage. In fact, they declined coverage, but now they've come out with coverage determinations where they are covering it for patients that meet the various criteria that I've mentioned. So I'm pretty long-winded, but I think that's our time. I want to thank you all for joining us on this, and feel free to reach out to me if you have any additional questions.